From the JAMA Network, this is JAMA Surgery Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Surgery.
Welcome, JAMA Surgery listeners. This is Amalia Cochran, the Web and Social Media Editor. And today I'm here with Drs. Crisanto Torres from Boston Medical Center.
Thank you, Dr. Cochran, for having me.
And Dr. Joseph Sakharin from Johns Hopkins.
Thanks so much, Dr. Cochran, for having us.
Today we're going to be talking about whole blood transfusion and survival in trauma patients with severe hemorrhage. I'm really looking forward to this conversation. I always start my author interviews out by asking how you as authors got interested in your research question. What stirred your interest in examining the impact of whole blood transfusion on survival in civilian trauma patients?
First of all, Dr. Cochran, I want to thank you for inviting me and Dr. Sakharin to be a part of this podcast and giving us the opportunity to discuss a little bit of our work. So, it's really been over the last 20 years where we saw the importance of damage control resuscitation, right? And specifically, one of the tenets of damage control resuscitation being hemostatic resuscitation. This is a way in which we could counter the coagulopathy that's induced by trauma, which in itself is associated with increased morbidity and mortality. And so we learned from landmark studies such as the PROMPT study and the PROPER trial of the associated improved outcomes with that hemostatic resuscitation. And so what that really entails is the importance of a well-balanced, high-ratio, 1-to-1-to-1 blood product transfusion of red blood cells, plasma, platelets, with the very best attempt to imitate the composition of whole blood. But unfortunately, at the same time, we learned that fractionalization of whole blood may also lead to a reduced hemostatic profile or efficacy. And so it's really been through the military's experience about the potential promises of whole blood. And the experience of whole blood spans back 100 years. I won't go through the extensive but yet interesting history of whole blood, but I will talk more about the kind of modern times. And so over the past 15 to 20 years, with the conflicts in Iran and Afghanistan, we learned that there has been a so-called renewed interest or resurgence or revitalization of the utility of whole blood. And so in the military's experience, they had used fresh whole blood, which is pretty much known as the walking blood bank, in which right there in the battle theater, you had soldiers giving blood and also using it within 24 hours, which is obviously different from what we use here in the civilian population of cold store whole blood. And so with that military's experience, once the data started to come out to show the potential benefits, that information started to cross over into the civilian population. And so it's really been the earlier studies by the greats such as Spinella and Brian Cotton, and then the later studies by Christine Leeper, who looked at it in the pediatric population, Bilal Joseph, and even more recently, Hazelton, have shown the promises of whole blood. But at the same time, the data continued to be small and at times even conflicting. And so it remained unclear what subset of patients would actually benefit the most. And that's why we specifically looked at patients who had severe bleeding. The other question was, where along the timeline of injury from ED arrival to hospitalization would patients really benefit? And so that's why we felt like it was very important to look at a survival analysis to help answer this question.
Yeah, and I would just add, Dr. Cochran, that this started off as a project that Dr. Torres was looking at while he was still here at Johns Hopkins. And part of it stems, from the interest of trying to build on some of the great work that's been done to really try to combat the number one cause of death in injured patients, which is bleeding. And really thinking about how do we go from what currently is the standard of care for resuscitating our trauma patients to perhaps the emerging choice of blood product, which appears to be, at least the data is suggesting, maybe whole blood.
For the study that you all did, you used the American College of Surgeons Trauma Quality Improvement Project Database, or TQIP. What was the benefit of using the TQIP data for this study, and what are the downsides of using the TQIP data?
TQIP right now exists in nearly 900 ACS verified trauma centers, right? And the database provides, of course, a nationwide sample of trauma patients that are presenting at these various centers. And the data that is being collected, of course, is risk adjusted patient and hospital data that is collected by really well trained abstractors and has external validation checks that are performed in order to ensure that they are maintaining this high quality data. Now, of course, not all research questions have the time or expense or even the resources to undergo a multi centered prospective study to address potentially clinical impactful interventions. And this is one of the reasons we decided to use TQIP, because it really provides a vast amount of data that we can utilize and we did utilize to really try to advance our clinical kind of question. Otherwise, you could imagine that if everything that we did, were based simply on prospective studies, we wouldn't have anything out there that's really substantial. I think it's important, as you mentioned in your question, to recognize, well, what are the disadvantages of using a database like TQIP? I think there's a couple things. When you think about some of the variables it doesn't collect that could be clinically relevant for our study, we're thinking about the lack of capture of TXA, maybe certain laboratory values such as coagulation parameters like INR and PTT, TAG profiles, and even information about those patients that may have received pre-hospital transfusion or even the type of whole blood that was used, right? So it's an incredible resource, and I think we recognize it for both its benefits and its limitations.
In the methods section, you all mentioned that propensity score matching was performed to address the difference in unbalanced comparison groups. Can you describe for our listeners what you mean when you say that the groups were unbalanced, and why was it important that you address this in your analysis?
Sure. So our study design being a retrospective study, we intentionally included all participants who met the inclusion criteria in order to have as much statistical power as feasible. And so this reflected the proportion of those who received whole blood as an adjunct to MTP and also those who received MTP alone to the fact of interest, and ours being survival time at 24 hours and 30 days. And so this was an advantage in some sense because we did not have to recruit participants. But the downside of that is that unlike randomized trials, there could be large characteristic imbalances between groups that may arise and be a source of significant differences that can lead to biases. And so when you have unbalanced comparison groups, this may cause concern for confounding, and more specifically, confounding by indication. And so, for example, one group may have received the treatment based on how they look, and this may either underestimate or even overestimate treatment effects and results. And to further elaborate on that, let's just say that I'm in the trauma bay and I have right next to me a fridge of whole blood. If I have a patient that comes in who is severely sick, well, out of convenience, that patient may get whole blood as their first blood product of choice. And so more patients who are sicker may receive whole blood. And in that case, the treatment effect may be underestimated. But conversely, at the same time, just because of convenience, I can have a patient who may not be that sick at all and may receive a blood product or whole blood transfusion very early in their clinical course, and those patients may have done well otherwise. And so that's the issue with confounding by indication and what you may see in these unbalanced comparison groups. So a way to kind of counter that issue or even mitigate that issue is by performing propensity score analysis or a propensity score match, in which what we did in our methods to control for many confounders that may arise from unbalanced comparisons. And so this may hopefully mitigate issues such as confounded by indication. So just briefly, what that entails is that patients are matched one-to-one on all characteristics or variables that may be responsible for confounder. And so although the power may be reduced due to smaller sample sizes, the internal validity of the results is further strengthened when the direction and magnitude of association align with the results that we saw from the unbalanced comparisons.
Thank you for that clarification. Clearly, the improved survival, both short-term and the intermediate term, is the most important finding from your study. I did think that the longer length of stay in the whole blood group was interesting, however. Do you have any thoughts why this might have been the case?
I think anytime you look at length of stay, it of course requires a really careful interpretation. And I would say in this case, probably likely, future additional analysis. In our current analysis, we included all patients in the length of stay calculation, including patients who died or who may have been transferred to another facility, and patients who received the massive transfusion protocol only may have a lower length of stay because of a relatively higher mortality. This is something that we're currently looking into to further study this and examine it. I think there's a variety of different approaches that you could do to help evaluate this. You could restrict the length of stay analysis to those who are surviving to discharge to home, or use a time to discharge approach. And each of those have its own advantages and drawbacks, but it can potentially further help us inform this length of stay question that you bring up.
Was there anything that you were surprised by in your findings?
Yeah, so there were two things that really stuck out when the results started to really declare themselves. And the first one was how early the survival curve separated between the two groups. If you look at the survival curves, we really start to see that nice, clean separation, even at around 5 hours from ED arrival. And that just continued on through the study of 24 hours and 30 days. And so this really demonstrated the possible early benefits associated with whole blood as an adjunct to MTP. The other thing that really stuck out was that a single intervention, such as 1 unit of whole blood, can be associated with such a clinically significant improvement in outcome. But if you really think about it, 1 unit of whole blood, although may be a single intervention, should actually be viewed as a highly efficient intervention, right? Because really, as a single product, the potential benefits could be related to its ease of use. For example, one bag is delivered compared to multiple bags for each component being transfused. Also, the efficiency to facilitate an early high ratio resuscitation.
Yeah, I think that's an important point, right? You're taking this 1 unit of whole blood and you're essentially saying this is highly efficient because it's essentially equal to many units as you think about it from what we're currently doing with blood component transfusions. And I think that's going to be quite interesting as the data continues to come in.
Yeah, the analogy that I like to use for this is your smartphone, right? 20 years ago, we had to do so many things, whether fax machine, computer, if we wanted to watch television, there were so many different components, right? But once these smartphones come out, we can do everything from a single device. So it may be a funny analogy, but that's the best analogy that I can think of, where you have all these different components that are part of this whole blood. And again, you shouldn't really think of it as just a single intervention.
I also really appreciate the fact that it has the potential to be volume sparing, which in certain settings can be really important with certain patient populations.
Absolutely. And it just further substantiates the part of damage control resuscitation where we aim for that permissive hypotension. And so with the volume sparing effects, we mitigate the issue of over resuscitation and potentially so-called popping the clot.
So, my next question is, have you all integrated any of your findings into your clinical practice?
Yeah, so here at Johns Hopkins Hospital, we've currently been active in transforming how we resuscitate patients in the trauma bay. And we actually just finished the draft of a new protocol that is specifically tailored towards giving whole blood in our trauma patients that are coming in as activations. And so we're really excited. We're planning to roll that out just after the new year. And so this study, as well as the numerous other studies that Dr. Torres has mentioned, I think has helped convince many of us that care for injured patients that the time is now to really start changing the paradigm in how we approach these critically injured patients.
Yeah, just want to reiterate, it's pretty much similar to what we have here at our institution as well, where we have patients with severe bleeding or at risk for severe bleeding. They are given a max or up to 2 units of whole blood directly from the trauma bay freezer as the initial resuscitation product, followed by component-based MTP.
What next steps are you all looking forward to for your work in this space?
We're currently evaluating and analyzing the impact of the timing of a whole blood transfusion on clinical outcomes among all patients who received whole blood as part of their MTP for severe bleeding. And we feel like this is a very important question to consider because it may provide further insight on an optimal time window for benefit and if later transfusions may be associated with worse outcomes, similar to what we saw with TXA.
Yeah, I would just say that I think it's a really interesting time as we think about resuscitation of patients. And as we look over the past 10 to 20 years, you can kind of see the pendulum swinging back and forth, whether how much fluid you give, what blood products are you giving, what's the ratio. So it is literally so exciting to be at the moment we're in where now we're starting to collect robust data that's allowing us to figure out in patients that are arriving to our trauma centers, how do we adequately resuscitate them to ensure that we're providing them with the best possible chance of survival. And I think it's just a great time to be in our field. And who knows what we'll be doing in 10 to 20 years, but I suspect it'll continue to develop and change.
Dr. Torres and Dr. Saccharin, thank you both so much for your time today.
Thanks so much for having us, Dr. Cochran.
Yeah, Dr. Cochran, thanks a lot.
This episode was produced by Daniel Morrow at the JAMA Network. The audio team here also includes Shelley Steffens, Lisa Harden, Audrey Foreman, and Marilyn Furkalek. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thank you for listening.